We are in a lucky situation in the Netherlands. We don't really have to look at costs. Everything is paid for. We don't have a London consortium which is forcing us to go to combinations which we probably don't like. And this is actually the continuum of care for the whole country. And as you can see, we are doing almost what UNH wants us to do at 2020, and these were numbers from 2015. In Amsterdam, we participate in the so-called fast track cities program. So that means that we try to do as good our best on every perspective of HIV care in the Amsterdam area. And there you can see what this means. You see that the continuum improves 94%. But now looking at, if you look at, because you live in you work in your hospital, and knowing the numbers of the country is nice, but it's probably much better to see what you do in your own hospital. And this is actually what we calculated recently, the cascade of care for people who are referred to us and how are we performing. And I'm not going to go into the details. You see the number of patients we have to take in responsibility for, and we come to a percentage of 97%. So actually we, virologically, if you focus on virus, we probably are at the maximum of what we can achieve. So we discussed in our group, how can we do better? If we are already there, is this it and we go and do something else, or is there something to go beyond detectable? And therefore we thought about a program. You heard Guido van den Berg talk about it yesterday a little bit. We designed a care path, patient-centered. We focused on valuable parameters. And the valuable parameters were designed through the concept of value-based healthcare. And we wanted to focus on the patient, because it's the patient we're doing the work for. It's not because of our satisfaction of our work, it's for the patient we are doing the work. Value-based healthcare. So it's about the value for the patient, and as you heard Guido tell yesterday, by the concept of Porter, we looked at, you first have to improve the healthcare in the acute phase. You have to go to recovery, but then more importantly, and especially in HIV care, sustainability of health is very important. And as we discussed yesterday, quality of life is paramount for the quality of your life that you have to sustain. So this is the topic of my talk today. We're going to tell you how we approach this problem of quality of life. Quality of life is asking the patient what he thinks about he's doing, not about his viral load or not about his kidney function. It's about how he feels, how he's performing. So that's PROMS, patient-related outcome measures. That means you have to ask them in a systematic way. So we routinely put the questionnaires in our care path. I will show you in a moment. You have to do it online, because if you do it, of course, people who don't have a computer, you can ask them to fill in papers, but then somebody else has to put it in your computer, and that's very inefficient. And you have to do it, of course, understandably. So we wanted to have questionnaires in Dutch, but most of our patients speak English as well. If we have Spanish patients, they cannot talk with me, so they should speak English. And these questionnaires, of course, have to be validated. So that's what we try to do. This is the care path Guido showed you, and you see that, for instance, in the first year, in our care path, we want to have a questionnaire immediately at the beginning, and that's not very easy, I can tell you, because patients are most of the time emotionally disturbed, and if you immediately come with a questionnaire on how you're doing and fill in all these questions, so this is a challenge. But you see in the first year, because we want to see in the first year if indeed we achieve a certain level of quality of life, we have to measure that in the first year. And in the chronic care phase, which enters, of course, after that, we want to do it once a year. What are the questionnaires? These are the questionnaires we picked from all kinds of modalities. In total, we have a questionnaire of 62 items. It takes around 15 minutes. And actually, this is what you ask your patient. You have to invest in the evaluation of your health. You do your blood test, you do your blood pressure, but this is also a part of evaluation how you're doing. So, and it's a mind shift for patients, because normally they discard, as you probably do at home as well. If they send a questionnaire to you to fill in, you say, well, do it another day. But now we have to stress to our patient, this is important for their own health. And this is here you can see what we do. We do this is the, of course, the SF12. You see, we look for depression, we look for stigma. Well, this is the whole list. This is the timeline where we are. We first started to, because every questionnaire is validated on its own, but to do it all together, that you need a new validation process. So that's what we did April last year. We needed 170 questionnaires to evaluate. And that means that around a few months later, we were ready to launch our care path, including these questionnaires. So that means that since patients come twice a year to the hospital, 6 months later, the questionnaires were coming in. And here I want you to show a few of our first experiences. We use this evaluation for our quality evaluation in our team. So we have a team feedback for every item in the value-based healthcare items. But because I had to give this talk, I asked my data manager, please produce the results of the 1st of August so I can discuss with the group here how we are doing right now. And I will, from all these periods, show you a few examples. This is from the validation phase. We had 170 questionnaires, and this is a typical way of showing quality of life in a spider web. Of course, we're not allowed to do it this way, but we compared it with historical studies from diabetes in the Netherlands, but also with historical evaluations of the general population. And what you see is interesting, is that people with HIV tend to have more problems, because this is 100% and this is 0%, tend to have more problems in the mental health, in the emotional situation, in the social function. You see the blue lines are far below diabetes. Diabetes is also lower if compared to the general health population. It's not compared in the same way, so this is not science, but this is only to give you an impression that you're indeed measuring something which makes sense. I want to focus a little bit on one of the most scientific questionnaires, which is the HATS. I probably don't know if you know it, but it's about anxiety and depression. It's a very well used by psychiatrists. If you have depression, they tend to use these questionnaires as well. It's a questionnaire of 14 items, 2 subscales. One of them is about anxiety, one of them is about depression. So the total score ranges from 0 to 42. Higher scores indeed represent more distress, and what is in all kinds of studies said, if you score above 15, you have a good chance of being depressed and having a serious depression, and the higher the score is, the more serious your depression is. So 15 for HATS is an important value. So we had a team feedback in June on the first questionnaires that came in a few months when we were busy with our care track. We had at that moment 278 questionnaires from the 460 that were sent out. So you see that not everybody is responding so far because it's new. And the protocol we use is, well, if you had a HATS above 15, you need to take action. You need to refer them to a psychiatrist, or at least discuss it with the patient. What are we going to do with your depressive mood? But as we found out, well, as always, you can launch a protocol, but if not everybody reads the protocol very good. So what you can see here, you see that most of the patients had a HATS less than 12. This is fine. But 60 patients had a serious indication to discuss their depression. And if you look within the team, well, in 22 of these 60, it wasn't even discussed, it was ignored. Probably it's also new for us as doctors. So you can see that for us, there was a feedback, oh, we need to take care of this because we are measuring it, so we should take action. So this is also, we use this for internal feedback. Individual, I have a few examples. This is a case of a woman who came to our hospital with a very recent HIV infection. She felt very sad. She had lifelong 2 sexual partners, and now she became HIV infected. So she came in August 2016 saying, well, my life is really useless. I don't think I want to live anymore, etc. Well, you can recognize this kind of picture. We were not using these questionnaires at that moment, but I saw her recently. And I was really curious, well, what will these questionnaires do with her? And I was quite surprised. She had a HATS of 6. And this is one of the other questionnaires which estimates self-esteem, and it scored the highest level. And indeed, she was saying, well, I feel perfect. So I confronted her with a year ago, and she did a lot of things on her own with her partner, etc. So indeed, this questionnaire confirms what the feeling of the patient is telling you as well. Oops. A second case, a very recent case, a man of 45 years of age, MSM, came in May with a advanced HIV diagnosis. He was diagnosed because he had weight loss. You see his CD4 number, you see his viral load. We started with antiretrovirals immediately, but he was, because he felt so depressed about it, was really suicidal. So we made an emergency referral to the psychiatrist. And in August 2014, he said he was doing better, and also his numbers were better as well. You can recognize this also. But this is interesting to look at his HATS. When he came in, he had a HATS of 27, so indeed it perfectly measures that he was feeling not very well. But within 3 months, you see the HATS going down to very normal levels, both on the level of depression and both on the level of anxiety. So you can use these questionnaires in a more scientific way to really see what's happening. You can give it a number. Okay, this is about HATS. Now I'm going to give you a little bit of an idea about all the other questionnaires we are using. And this is the evaluation I made before, because I had to give this talk. At the 1st of August, we already sent out almost 1,100 questionnaires, 640 returned, so that means that 55% is returning the questionnaire. So we have some work to do. Also, not every patient that has to be sent a questionnaire had received the questionnaire. That's a more logistical issue, so we had to perform as a team better. And in total, 600 individuals participated, so that means that some individuals, for instance the new ones, returned more of the questionnaires. In our hospital, we have a very large population of MSM, so it makes sense that we have more response from male individuals, and the average age of those who returned the questionnaire was 50 years. This is first again to start the HATS. I showed you a little bit the HATS, what it means. 15, the number of 15 is important. And here you see the distribution of all the individuals who returned their questionnaire, and here's the box plots with the numbers. You can probably not completely read the numbers. And if you take into account what's normal and what's abnormal, and I want to focus you on the total HATS with the number of 15, you can see that around 25% of our population indeed has depressive moods. And we probably do not fully realize it. We only focus on viral loads, as doctors, on creatinine, etc. So this is probably to improve the quality of these patients' lives, we have to probably focus a little bit on this aspect as well. What about the other questionnaires? Sleeping disorders, self-esteem, more or less the same. You can see a large distribution in how patients return these questionnaires. And now we have a little bit of a difficulty in the literature. It's not very clear what's normal and what's abnormal. So therefore I put the question marks here. And if you take this as a question mark, well, especially for instance for sleeping disturbances, it means that some way or the other, 77% of our population has some amount of sleeping disturbances. We do not know, if I send this questionnaire to you, what the percentage of sleeping disturbances is here in the audience. It's very likely that with this kind of questionnaires you probably return 35% of you in the audience has this as well. So this is, we have to find out what's really important, but now you realize that you probably can do something better for your patients. And the same is, for instance, for self-esteem. 65% of our patient has a low self-esteem, which definitely will influence his depressive mood or his sleeping disturbance. So all these questionnaires, of course, are interrelated. Social support and stigma. I think stigma is of course, always an issue we realize is important, but we have not really a tool to measure how important. So that's something we try to quantify. Social support, again, we do not really know what's a good social support and what's indeed a stigma. Again, the question marks. But that means that if you look at the lack of social support, so you have to view this graph in another way, more than 62% experience not a good social support because of their HIV. They have, for instance, one of the questions is, Are you invited to birthday parties and you have the idea your HIV is involved if you're ignored? Well, these kind of questions come into this social support questionnaire. And what about stigma? In the international questionnaire we use about stigma, the Berger Stigma Index, the level of 2 is more or less said if you're above 2, you experience some amount of stigma. And that means that at least 50% of our population is experiencing some type of stigma. And some of them only mild, but also here you can see that there are quite a few individuals that seriously experience stigma. So this is more or less what I can show you about our experience with all these questionnaires. And these are, I think, our interim conclusions. It's not very scientific at the moment, it's more of a sense. First of all, I think it appears to be very feasible in routine care. It takes extra time, of course, to discuss with your patients, hey, what is your questionnaire? It takes you extra time. That means that every year we have an extra time slot for a yearly visit to discuss all kinds of items, cardiovascular risk, adherence, of course, that's something that always comes back, but also what was the response on your questionnaire. But very interestingly, most of the patients appreciate it very much. I know some of my patients already for more than 20 years because I'm working almost 20 years in the LVG. And interestingly enough, it opens a new perspective in the discussion. I never discussed social support or stigma with my patient, and now suddenly they come with this, and it's new, and that's always exciting to do something new. We have work to do. We do not know what's abnormal, but we have the idea that abnormal values occur quite with a high prevalence. We have to do better. We have to increase our response rate, of course. So the team has to perform better. We have to find out what's abnormal, as I said, but in particular, of course, we have to find out what's alarming. And we have to find out, as I just said, if you have a low self-esteem, it will definitely influence your mood, it will definitely influence your sleeping, etc., etc. So the interactions between the questionnaires, that's the field of research, and of course that's interesting as well. We also found out that you cannot use these questionnaires for everyone. Surprisingly, patients sometimes don't have a computer, don't have an email address. Well, you can hardly think that in 2017 people don't have an email, but they have. And we have barriers. There are cultural barriers, intellectual barriers, because some people simply don't understand the questions. And they go to a neighbor or a friend and say, can you probably help me in filling in these questionnaires? And then my neighbor has to translate if you have a question about sexual functionality. Well, this is not the way you should want to handle. It's very private. And there are social barriers as well. Some people simply say, we don't talk about sex. What are the future plans? Well, we can measure all these things, but we need to make also an action. As I said, for the HOTS, the depression, we already are busy working on a psychiatric care path. So in our HIV care path, if a patient indeed has a HOTS above 15, we want to at least put somewhere in the care path if he is transferred or not to the psychiatrist. But also, I think in particular for stigma, we talk a lot about stigma, but we want to do something against stigma. And we are busy with making a program for self-empowerment in collaboration with patient organization. And the interesting thing is, because we have these questionnaires, we can see, because we follow it longitudinally, if these questionnaires indeed improve after our intervention. Of course, we have to find out what extra investment we need to make. Do we need a psychologist in the team? Do we need new training? I think we need new training, because I don't know how we should deal with all these kind of things. We want to put our questionnaires not by email in a computer, because a lot of people don't like the computer anymore. Everybody works with their handheld health, so we want to put the questionnaires in the PDA. And a lot of research, of course, needs to be done to do everything I just discussed. So this is about the questionnaires, a little bit going back to the value-based healthcare approach. The questionnaire is only a part of this value-based healthcare approach. If you want to do it the way we are doing, it was very important that you need a data manager in your team. You need to have data which are up to date, as I said, I had to get this presentation, so I asked my data manager, and I got the results from the 1st of August, not from a year ago, but from the 1st of August. It has to be incorporated in the electronic health record, and in the OLVG we use EPIC. Without that, I think you cannot really do that. If you need somebody to put it in a database, and then the database has to be evaluated, and you don't have insight in what's in your database, so you need it in an electronic health record. And fortunately, for instance, EPIC can help you very much with this. And I think most of the hospitals are working now with programs like that. It helps us very much because we had in our team a very much of a quality impulse. Every month we discuss one of the items in this value-based healthcare. So why are we doing it the way we do? What's the achievement we want to make, and why are we not reaching it? But more importantly, of course, we have the idea we improve the quality for our patients in all respects. We are working on this program, and other hospitals in the Netherlands are very much interested, so we will have the opportunity within the country to do benchmarking. There is an international group for the value-based healthcare from Michael Porter, which is called ICHOM, and we have been in discussion with ICHOM. Can we submit our parameters as the HIV parameters for the international value-based healthcare HIV approach, and we are working on that. And interestingly enough, because now I was only talking about the quality, and the previous speakers talked about costs. Well, cost is of course very important for the value-based healthcare approach, and health insurance companies are very much interested in our approach because you can focus on the things that were discussed, but you can also see the health insurers also see how much money is paid for a psychiatrist, how much money is paid for a cardiologist, how much. So they want to do bundle payments in our program, and this is new for health insurance in the Netherlands. Looking a little bit further in the future, where are we going? I'm almost done. Probably in the future, and we hope the future is in 2019, a patient who is doing well comes to the hospital with no appointment. He knows he has to be in the hospital at a certain moment, but he's not scheduled to my schedule, but he's scheduled to his own schedule. He comes to a hospital, somebody takes his blood pressure, his blood is taken, he fills in the questionnaire or other questions he is asked by his PDA, smoking status, etc. And you saw yesterday the Happy app, Guido showed it. Well, this might be an example. And if you do what you are expected to do and fill in all these questionnaires, and your program says, well, you're doing well on your viral load, you have a good treatment adherence because that's measured in your PDA, your tolerance is well because you feel that in your questionnaire, your creatinine is well, your liver tests are well, your cholesterol is well, your cardiovascular risk is calculated, whatever kind of questionnaire you're using, and it's also a smiley, and you filled in your questionnaire for quality of life and you don't have a depression and your Stigma Index is okay. Actually, there is no need to come to the hospital. Why should you? You're busy, you're working, you're traveling. So what the PDA gives back the response, your next appointment will be in 6 months. We suggest the 1st of April and in 2020, but it should be a personal visit because you need to have contact with your patients personally as well. And well, this is probably not feasible for every patient, but we think in the modern eras, and people will like this, in particular the group of patients we take care of, it's an optimal tool for self-management. We can make it interactive. So if he has complaints or there are events happening, he can use his PDA to contact the team. But you can also use these kinds of applications to give him news, new developments, to also give him education. If there is a good paper coming out and you send it to your patients and you ask him some questions if he understands the message, for instance, the U is you, as we discussed yesterday. You give him links, etc. So we can use this very much. And this is not what we invented, actually. There is a program in Los Angeles for colitis ulcerosa, so it's not HIV, colitis ulcerosa, which more or less uses this kind of approach. Health insurance is very much involved, and interestingly enough, if patients participate fully in that program, they get a 10% discount for their health insurance, which is a very highly motivation for patients to really participate in programs like this. Well, this is future. but I don't think the future is not unrealistic. I hope I enjoyed you. I also want to invite you, next year we have the HIV conference in Amsterdam. We hope to give you some more information about our program. We also want to invite persons to come to our hospital so they can look in how we are doing. And I want to thank you for your attention.